Welcome to the Health Channel, All Health All the Time. I'm Olga Villaverde, coming to you from the South Florida PBS studios. Prostate cancer is the most common cancer among men. Fortunately, though, according to the American Cancer Society, the average 5-year survival rate for all stages of prostate cancer is 99%, and that is a great number to report. Today, we'll be talking about the different therapies that may be used to treat this cancer, specifically focusing on radiation and proton therapy. And joining us today to explain these procedures is Dr. Marcio Fagundes, the Medical Director of Radiation Oncology at Miami Cancer Institute. Welcome, Doctor.
Thank you very much.
Thanks for being here, because this is really a prevalent topic that affects so many men in our country, correct?
Yes, and it's important to say that for early stage prostate cancer, the success rate is so high.
I know.
Like, up to 99% of patients can be disease-free 5 years after treatment. These are studies that have recently come out, for example, with proton therapy. Now, as we go to more advanced stages, the cure rates do go down. But early stage, the success rate is quite high.
And we're going to talk about how to detect early, which is so key to just so many cancers, breast cancer, prostate cancer, and the list goes on and on. But first, before we talk about prostate cancer, the proton therapy, and everything our viewers need to know, first I just want to talk about prostate cancer and how it's treated. What is the function of the prostate? Let's start there.
So the prostate has both reproductive functions and urinary control sphincter functions. So from a sphincter control, obviously the prostate is situated between the bladder and the urethra, and it has the valve control of the urine. So the patient holds urine when he wants, and he releases it when he wants. There's also reproductive functions. So the prostate and the seminal vesicles contribute fluids to the ejaculation for reproductivity.
And how prevalent is prostate cancer? Because you hear about it a lot, especially as men get older. It seems like it happens more often, maybe after the age of, I'm going to guess here, but maybe 65?
Yeah. So this is a really important question because, up to about, well, it's the most common cancer in men.
Correct.
180,000 men diagnosed with prostate cancer in 2016. 1 out of 7 men will have prostate cancer in their lifetime. And if we think that prostate cancer can't be aggressive and kill patients, that is wrong. It does. And it's actually the most common cause of death in men after lung cancer. 26,000 men died of prostate cancer in 2016. So it is a cancer that it's better diagnosed early, when it's most curable, so that we can prevent all these deaths.
And oftentimes there are not many symptoms when it's the early stages. That does not ring true for advanced prostate cancer. But we're going to go through some symptoms that you, as a man, should really look out for, because that's what you want. You want to detect it early. And here are some of them, Doctor. Let's run through them. Problems urinating. That's a big one.
That's a big one. And frequently prostate cancers, when they're small, they're situated in the back part of the prostate, away from the urethra, so they can be silent. So a patient can have a small prostate cancer in the periphery of the prostate and not having it pressing on the urethra where the urine is flowing, so the urine seems to be normal. Now, in some cases, when the prostate cancer is larger or the patient has some prostate enlargement, there can be urinary symptoms. So this could be one of them.
Okay, and look out for also blood in the urine or the semen. That's a telltale sign, isn't it?
It can happen.
Yes.
It can happen. Again, it's not that common. It's more common that we find early stage prostate cancer without symptoms, where the only thing you find is a rising PSA, which is a blood test.
Exactly.
And we may actually feel the cancer on a rectal exam, a finger exam, because 70% of these prostate cancers are situated, as I said, in the periphery of the prostate towards the rectum in the back part. And with the finger, we can feel them.
We had a couple more there. Let's just run through them quickly. We had erectile dysfunction. We also had pain in the hips, back, chest. If we could bring that back up, Ed, thank you so much. Weakness or numbness in legs or feet, loss of bladder or bowel control. So again, symptoms to look out for.
Yeah.
We also have risk factors that put men obviously at risk if they are going to get prostate cancer. Let's go through some of them. Obviously, one of them is age. We talked about that. Age, race, and nationality. That's another one, Doctor?
Yeah, some nationalities have very low incidence of prostate cancer, while others have higher. Age is certainly a driving factor, but also family history. For example, if you so we talk about screening, right? For the average person who doesn't have a family history of prostate cancer, they can start doing PSA for screening at the age of 50, for example.
All right, so 50 is kind of like the cutoff mark that you would say.
And digital rectal exam also at the same visit as a PSA check, and do that on an annual basis. But if you have a first degree, more than one first degree relatives with prostate cancer.
Like a father?
Yeah, father and a
Abuelo?
brother, or
A grandfather?
first degree relatives. Then you should start doing screening at the age of 40.
Okay. It's
So
almost like women with mammograms as well.
Right, right.
Yeah?
Yeah, so African Americans are recommended to have screening starting at the age of 45 because they do have a slight increase in the incidence of prostate cancer.
All right. We mentioned, obviously, age as a risk factor for prostate cancer. So how does age play a factor when it comes to screenings? Urologist Dr. Matthew Talefson from the Mayo Clinic has more on that. Take a look.
The recommendations really don't change for men over 70. So men over 70 generally, if they're otherwise completely asymptomatic with no family history of prostate cancer, probably don't need to be having PSA tests every year. And those men, are very, very low risk of dying of prostate cancer. But for men that are younger, so men from 55 to 69, there can be a benefit seen with screening. And so this is where the task force is now giving nuance to the discussion and basically saying that there's not a blanket answer for everyone. The benefit of screening for men from 55 to 69 would be the benefit of catching a cancer earlier when it's easier to treat and potentially cure. And so if men are screened, then potentially that tumor could be identified when it's at a curable state, and then they could undergo curative treatment and reduce their risk of dying of prostate cancer.
All right, so for our viewers that just watched that, I really want to clarify, because, you sometimes hear different things, and this doctor said every other year. As the package was rolling, the doctor and I were talking about every year. So in your opinion, doctor, if there's a family history, one should start at 40 and possibly get that test every year, correct?
Right, more than one relative, first degree relative, start at the age of 40.
And if there is no family history, then
At the age of 50.
50.
Yeah.
And would you say every year or every other year?
Well, I mean, we look at PSA velocity, and I'm not sure that was quite clear in the statement, but as the PSA rises slowly, small increments of PSA are okay, but if the PSA rises more than a certain amount per year, that is a flag. So we look at that. So
And
if
can you explain that PSA for us?
So PSA is basically an antigen, a protein that is measured in the blood.
Okay.
It's prostate-specific antigen. And it's a simple blood test. You draw blood, you get the results within 24 hours. If the PSA goes up more than, say, 0.75 nanograms, that's the unit, per year, that's a flag that something could be happening. Now, let's make sure that people understand. Other things can rise the PSA, like a prostate infection, inflammation.
Okay.
So that's why we want to monitor these rises and understand what's causing them.
And we have a few tests. The doctor mentioned a blood test, a prostate-specific antigen, PSA blood test. There's also a digital rectal exam, which is DRE, if we could talk about that, doctor. And any other tests? So can you go through those?
This is very important because sometimes the PSA does not go up in patients. In some patients, this is rare, but it can happen. The PSA does not necessarily go up much, very little. And some cancers are picked up only by the digital rectal exam.
Wow.
So patients will ask, well, can I do just a blood test? No, because you might be missing 1 in 10 or 1 in 20 patients that have a cancer that the PSA does not rise. So you would pick it up on a digital rectal exam.
Okay, and when the stage is, I guess, diagnosed, because there are different stages, like let's say those levels go up, if I remember correctly, because I was a pharma rep, you can take some medication to kind of bring those numbers down, correct? It doesn't instantly mean that, you have cancer and we've got to do something about it.
Right, so basically for intermediate to aggressive cancers, like the Gleason 7 is a score of the aggressiveness, or Gleason 8, 9, 10 is a more aggressive score, the most aggressive. These cancers tend to be treated with hormone therapy, blocking the testosterone and radiation combined.
Okay.
So hormone therapy, medications are used in the combined treatment setting. Right.
And there are different stages of prostate cancer. Can we talk about those?
Right.
Are there levels? Do you diagnose them with numbers?
So basically, we look at 3 main factors, right?
Okay.
The how big the cancer is. Is it confined to the prostate? Is it palpable? Does it extend beyond the prostate? That's the T stage. So we look at that. The second one is Gleason score. The pathologist gives us that. He looks at the biopsy, and if he sees cells that look pretty normal appearing but still cancerous, but almost normal, they call that a Gleason 6, a low score.
Okay.
Intermediate is a 7, and then there's 8, 9, 10 Gleason score. Gleason is the name of the pathologist who described this. Those are aggressive cancers. They tend to grow faster, more likely to spread. So basically, you have these 3 levels: low risk, intermediate risk, high risk. Then you have the PSA. PSA less than 10 is good, low risk. PSA over 20 is high risk. In between 10 and 20 is intermediate.
Okay.
So any scenario that is high risk, if you have a PSA over 20, a Gleason 8 or 9, 10, or a cancer that is extended beyond the prostate, these are the patients that need more aggressive therapy, like hormone therapy and comprehensive radiation, radiating the prostate and also the lymph nodes.
So it's important to get checked. It's important to get those numbers to see where you are to prevent that excess that you don't want to be at.
Right, and these high-risk cancers, the cure rate does go down some. So you want to diagnose as early as possible. You want to be vigilant.
Again, because
it's
of a
very important.
99% success
It's
rate.
your early stage, yes.
Which is fantastic. Okay, great information, doctor. We're going to take a quick break, but when we come back, we're going to be talking about the different treatment options available for prostate cancer, including radiation and something called proton therapy. So in case you haven't heard about that, we're going to dive into that as well. You're watching the Health Channel, all health, all the time on South Florida PBS. If you have a question for Dr. Fagundes, he is right here waiting for your phone call. Toll-free number right there on your screen, 855-796-4475. Be sure to visit our website, allhealthtv.com, where you can watch videos from previous episodes, or you can even submit questions for the experts, and we will be right back. Stay tuned.
Hi, this is Terry Bradshaw here to remind you that rheumatic diseases like rheumatoid arthritis and lupus are important to know about. If you're like me, you don't have time for flare-ups to slow you down. That's why I've taken the American College of Rheumatology's pledge to live well with rheumatic disease, and you should too. Things like eating healthy, staying active, not smoking, and managing my stress keep me going. Visit simpletask.org to take the pledge to live well.
We develop quality citizens who keep our core, our country, and our communities side by side on the winning side. Not for glory, but for honor. For a code that isn't written or spoken, but lived. It's what we do. It's who we are. It's the battle cry of our fighting spirit. Battles won. See all the battles Marines fight to win at marines.com.
Us lives here, where we can be surprised by others and ourselves. For a better us, support your local Y today. Us. It's what this country is made of. But right now, our bond is framed. How do we get back to us? The Y fills the gaps and bridges our divides. Support your local Y today. Because where there's a Y, there's an us.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us is Dr. Marcio Fagundes, the Medical Director of Radiation Oncology at Miami Cancer Institute. If you have a question for Dr. Fagundes, please call us using the toll-free number right there on your screen, 855-796-4475. We would certainly love to hear from you. We're talking about prostate cancer today. So, Doctor, let's talk about some of the different treatment options, and we have a list of some of them. So let's take them each one by one. It's a pretty large list, but all of them are very important. Active surveillance, that's the first one. Can you chime in on that?
So active surveillance is basically when you have a patient with very early stage cancer and has a low aggressive appearance under the microscope, and a patient that we feel that can be monitored and watched over time, where we do a PSA check and a digital rectal exam every 3 to 6 months.
Okay.
And he has to have a biopsy, a repeat biopsy every 1 to 2 years. So it's an active monitoring. It's not simply forgetting about it. It's not treatment, but it's staying on top of it.
Keeping an eye.
If the cancer grows or if it changes nature to slightly more aggressive, then we decide on proceeding with treatment. The point is that some patients will never need treatment if these cancers can be so indolent, grow so slowly, and maybe they're later in life, 75, 80-year-old patient, we look at the longevity and we say, is it worth doing treatment now, or can we just defer this and maybe not even need it? That's basically the concept.
Okay, I kind of equate it to a cyst that I have, for example, in my ovaries, and the OBGYN is always monitoring and watching it.
Yeah.
Hasn't done really much with this cyst that I have. However, we are vigilant and we are actively surveilling it. So it's kind of like the same thing, same concept.
Right, and you're using the PSA as well
Exactly.
to see if it's rising.
All right, okay, let's go now to chemotherapy, which is common treatment for this type of cancer. Is it
So
common?
chemotherapy is usually reserved for prostate cancers that are metastatic or spread
Okay.
into the bones, lymph nodes, or basically metastatic prostate cancer. Generally speaking, that's where we use chemotherapy. And patients will generally have either radiation and hormone therapy first, and if this doesn't work, in some patients, if it doesn't work, and the cancer advances and spreads, then patients will have chemotherapy. Well, this can also happen after surgery. If they have surgery and the tumor comes back as already metastasized, spread, they may have chemotherapy. But that usually comes after hormones. Hormones is the first line of therapy.
All right, so let's go to hormones, which is the next one,
Right.
hormone therapy.
There are two situations where you typically use hormones. One is in conjunction with radiation, to potentiate the benefits of radiation. So that is with the intent to cure, to eradicate all the cancer. So that's when you use it. We typically use it for cancers that are moderately or aggressive types, like the Gleason 7, Gleason 8.
Correct.
Now, if you have metastatic cancer, again, you might be using hormone therapy.
And the chemo, if I could just go back to it, any drawbacks with that one, doctor?
Well, chemotherapy tends to have, more side effects depending
Of
on the
course.
medication. It's not a treatment that you would be giving for 2 years like hormone therapy. It's a treatment you give over several months.
Okay.
But then again, hormone therapy has until this point proven to be the stronger treatment of the two, and the most impacting and beneficial to the cancer.
All right, the next one is obviously then surgery, if things start to be needed in terms of more
Right.
aggressive.
So this is important because this is one of the myths, is that surgery will eradicate and will remove all the cancer. This is very important because surgery will work better in cancers that are smaller, that can be removed more likely than not in its entirety. As cancers become larger, more aggressive, like cancers that infiltrate the capsule of the prostate or the limits, or cancers that have the higher Gleason score, Gleason 8, more aggressive, or the PSA when it's above 20. These are all high-risk cancers that I described. These cancers, if you look at national guidelines, the NCCN, that stands for National Comprehensive Cancer Network, national guidelines, you'll see that the treatment of consensus, first treatment, is hormone therapy combined with radiation. The second treatment that is potentially an option is surgery. Why is that? Because as cancers become more aggressive, you're less likely to remove all of the cancer cells. So if you try to do surgery, you will leave cancer cells behind. The patient will still need radiation. So at that point, you're doing two treatments, while you could have done hormones and radiation alone and not having gone through surgery. So for aggressive cancers, the preferred treatment by national guidelines is actually hormone and radiation.
All right, so let's talk about the radiation, which was the next one on that list. Radiation, what exactly does it do to the cancer cells? And are there side effects as well with the radiation?
Right. So radiation is basically non-invasive treatment, right? It's a beam of either X-rays, which is conventional radiation, or particles, which is protons. But what is it? What are they doing? They're basically impacting the cancer cells in a way that the cancer cells will end up dying. The cancer cells cannot survive that impact. The normal cells will recover from any, usual impact of radiation. We have advanced technologies today to minimize the amount of radiation that are delivered to areas that we don't want to radiate, like the bladder and the rectum.
Of course, because you don't want to hit that area.
Right, so we can minimize the risk of having any kind of injury. But radiation comes in three different scenarios. One is early stage prostate cancer, we only radiate the prostate. And we can even do this in just 5 sessions.
So it's just isolated to that area.
Right, it's called accelerated radiation, SBRT. Okay, that is basically very intense treatment to the prostate. The other extreme is the patient that has an aggressive cancer, a Gleason 8, PSA over 20.
Right.
Those cancers have a risk of spread to the lymph nodes in the pelvic area. Then we're radiating the prostate, seminal vesicles, and the lymph nodes. Typically, this treatment takes 39 visits. Monday through Friday, it's 30 minutes laying down, non-invasive, you don't feel anything, but this goes on for 7.5 weeks. And then you have the in-between, the patients that have cancer that is, for all we know, limited to the prostate, but we want to treat the prostate and the seminal vesicles right next door, but not the lymph nodes. These patients can be treated somewhat accelerated over 28 sessions, about 5 weeks of treatment. So there are different ways of doing radiation. They're all non-invasive.
I want to quickly show our viewers a graphic of some of the side effects you may encounter if you have some radiation therapy. Frequent urination, doctor, difficult or painful urination, abdominal cramping, diarrhea, painful bowel movements, fatigue, sexual dysfunction, skin reactions, and I think I passed one, which was rectal bleeding or leaking. These are just some of them, not very common, doctor?
Right, so this is an important list to show because here's what we tell patients. During the treatment, we will be hitting the prostate and the cancer. The urethra is coming right through the prostate, right in the middle. It will become irritated. So patients will have more frequent urination during the treatment. This tends to resolve within a month after we're done. Okay, now let's go to decreased erections. 2/3 of the patients that have normal erections before treatment will maintain normal erections 5 years later. This is published data. And so the preservation of erections with radiation is actually better than what we see with surgery. Let's go to loss of urinary control. It really doesn't show up in that list because it's so rare with radiation. Loss of urinary control, we almost never see that. That's more of a problem that happens with surgery. And then we have rectal irritation. And for that, we have one device that has come out in the last 3 years that we use in conjunction with radiation. It's rectal spacer. So it's pushing the rectum away from the prostate. It's one injection, and that's going to decrease the amount of radiation to the rectum and minimize any risks of injury to the rectum.
And I'm glad you brought that up, doctor, because to reduce these side effects, the Miami Cancer Institute uses a gel substance called SPACE OAR, which stands for Organ at Risk. This video is with Dr. Fagundes, who explains this gel and how it has benefited one of his patients. Take a look.
Patients who have prostate cancer frequently undergo radiation therapy as their preferred method of treatment. And it's a non-invasive treatment, but it can cause sometimes irritation of the rectum or the intestines. Rectal spacer gel is a way to minimize or even eliminate the risks of injury to the rectum. We inject this spacer between the prostate and the rectum. We displace the rectum away in such a way that the prostate then can be treated to a high dose of radiation, achieve high probability of cure, and the rectum is protected and has minimal risk of injury. This patient that we have here for treatment, we presented him with the option of having radiation therapy with rectal spacer gel. He chose to pursue this option. The rectal spacer gel is injected with a very thin needle. Patient gets up after a 20-minute procedure and walks out of the office. There's minimal discomfort that will last just a few minutes. The spacer gel is reabsorbed after 3 to 4 months.
When I met Dr. Fagundes, he explained every single step of the procedure, even with illustration, and he told me everything, how it was going to be and how easy it was going to be, and it was as easy as he told me.
It is most important for patients to know that we have now this method available at Miami Cancer Institute, that we can provide the best and most advanced methods of treatment.
I really like the Miami Cancer Institute because everybody I met here, they really make you feel like a part of the family, and they do it because they want you to be cured.
And coincidentally, the doctor just saw Regis Polanco last week for a follow-up, and he is doing
Great.
fantastic.
Yes.
That's great news. I'm fascinated with the video because it's amazing how that gel protects the other organs.
Yeah, so it's basically designed to go right between the prostate and the rectum, pushing the rectum away, so we can reduce the amount of radiation that goes on the rectum by 6 to 10 times lower amount. So I tell you, I've treated probably now over 500 patients over the last 3 years since this product was released by the FDA over 3 years ago, and I have never seen rectal bleeding after using this product. Now, we do this rectal spacer with all modalities of radiation, whether we're doing proton modality or conventional radiation modality. Is a protective addition to make the treatment even better.
And we have some scans here that we want to show you that show how the gel looks over the course of 6 months. So let's take these, and from left to right, doctor, let's explain this to our viewers.
So this is an MRI image. On the left, you see before placing the gel, the round dark area in the lower part of the image is the rectum. The rounded area in the upper part of the image is the prostate. Now, the middle one is right after the gel placement. And you have this white area. It's almost like a cushion there. A mattress almost, between the prostate and the rectum. That is about 1 centimeter to 1.5 centimeters, or half an inch space. So you can understand quickly now that we can deliver a large amount of radiation to the prostate, and the rectum is now displaced so far away that it receives much less. 6 months later, the gel will be reabsorbed. And this is biocompatible. It's similar to fillers that are used for cosmetic purposes. So this gel does not have any interaction with the body. It just gets reabsorbed and it's gone.
That's fascinating. And this gel is available to all patients, doctor, at the Miami Cancer Institute?
Yes. So most patients are candidates for this gel placement. There are very few exceptions. If a patient has cancer that invades the capsule towards the rectum, we might not want to recommend using the gel, but most patients are candidate for using it.
Great stuff. All right,
Yeah.
so we're going to take a quick break because we've also mentioned, we've kind of teased it. That's what we do on this show. We tease, so you stay tuned for proton therapy. And that's another fascinating topic, which is another type of treatment that can minimize side effects. So stay tuned for proton therapy coming up in just a couple minutes. You are watching the Health Channel, all health, all the time on South Florida PBS. If you have a question for Dr. Fagundes, he's right here on standby for you. Toll-free number, 855-796-4475. And please be sure to visit our website. It's fantastic, allhealthtv.com. Every single episode that we have done since we launched the Health Channel is there for you. Submit questions for the experts as well, and we'll be right back with proton therapy.
It is the most amazing gift that you can give someone. You're seeing individuals have an opportunity of their lives that they would never have again.
We all play a role in keeping our community safe.
Every day, we move in and out of each other's busy lives.
It's easy to take for granted all the little moments that make up our everyday.
Some are good, others not so much.
But that's life.
It's when something doesn't seem quite right that it's time to pay attention.
Because only you know what's not supposed to be in your everyday.
So protect your everyday
If you see something suspicious, say something to local authorities.
Addiction is a dark place, but just as each new day breaks, there is light. A light that illuminates the people by your side. Out of the darkness, you are walking with 22 million others struggling with addiction. The cure to darkness is light. The cure to stigma is love. And the cure to disease is treatment. Join us as we walk into the dawn of a new day. Together, we are stronger than addiction. Learn more at chatterproof.org.
I call you and say, I'm with your son. There's been an accident and he's in jail. He needs bail money, and you actually believe me. So you send cash fast and then, bye-bye. Think you're too smart to fall for this? Just last year, 150 million Americans weren't. 1 out of 3 of your neighbors lost $500. Can you believe it? You shouldn't. I made that up too. Maybe you will believe everything you're told.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us is Dr. Marcio Fagundes, the Medical Director of Radiation Oncology at Miami Cancer Institute. If you have a question for Dr. Fagundes, you can call us using the toll-free number right there, 855-796-4475. Love to hear from you. Another treatment option we haven't talked about yet is proton therapy. Now, this is a newer treatment, correct, doctor?
Right.
All right, so let's talk about first what it is and explain how it helps in this whole procedure.
Right, so proton therapy is basically a type of radiation that uses a particle instead of X-rays. These particles, protons, are accelerated to very high speeds, and they are directed towards the cancer, treating the entire cancer. The main difference from conventional radiation to protons is that protons will stop where we want. So we're treating the whole cancer area inside the patient, and they stop right there. So there's no dose of radiation that is delivered in the patient beyond where the tumor is. So we can avoid radiating areas of the body that don't need any radiation. So, for example, we were talking about prostate cancer. If you're treating the prostate and all the lymph nodes in the pelvic area, with protons, we send beams that come from one side and the other. They stop right on the lymph node chain and left and right side of the pelvis. And we avoid putting radiation dose in the central part of the pelvis, where the bladder and the bowel are located. So we can radiate much less of the normal organs with proton therapy. In this case, we can reduce the risk of diarrhea, even things that can last after treatment. Frequent need to go to the bathroom, to have a bowel movement. These things are less common with proton therapy than conventional radiation.
So when it comes to all the treatments, because we're going to talk more about proton therapy, but something just came to my mind right now. When it comes to the list of treatments which we did, which were there quite a few, is this your go-to? Is this the protocol you go for now, the proton therapy?
So proton therapy has situations that it's more advantageous.
Okay.
Compared to conventional radiation. For example, if you're treating all the lymph nodes, you're going to find that it's even more advantageous. There are situations where you're treating a small target in the body. It's a fairly small target area tumor, and there's nothing critical around it. Nothing critical, like no nerves, no spinal column, anything that is sensitive. Then any modality of radiation can treat. But if you go to some brain tumors, like the skull-based tumors, that's where protons first began creating their success story. that skull-based tumors in the brain are very close to the brain stem, to the optic nerves and so on. So if you can deliver radiation with high precision and stopping it before it reaches other parts of the brain, that's where you can give higher doses of radiation, improve the chances of cure. And that's exactly what happened with some of these skull-based tumors.
Fantastic. And speaking of where it began, the system for this treatment, the cyclotron, traveled nearly 5,000 miles from Belgium to the Miami Cancer Institute, making it the first in South Florida and one of a dozen in the nation. So let's take a look at its journey.
When I talk about what Miami Cancer Institute is going to be, it's going to be high-tech and high-touch, and nothing typifies that as much as what we're doing today, which is the proton unit. People don't have to leave their community for the highest technology care in the world. It's going to be right here. 5, 4, 3, 2, 1.
That is such an inspirational video. I mean, you can see how exciting it was for the Miami Cancer Institute to receive this back in 2017. And it really does change lives, doesn't it?
Yes.
I mean, it's amazing.
It is. And we have the most advanced proton technology currently available. And this is the only center in South Florida that has this, latest, most advanced modality of proton therapy that we have.
And I loved how the truck said, "Hello, my name is Pete." It was so cute how he was coming in, the proton therapy machine. And it's, by the way, it's not just for prostate cancer. There's a whole list of other cancers where this amazing technology is helping out. Look at the list, doctor. Base of skull tumors, brain tumors, breast cancer, gastrointestinal cancer. The list goes on. Liver cancer, prostate cancer, lung cancer, lymphoma. I mean, this is a game changer, isn't it?
Yes, it is. Yes, it is. And pediatric tumors are frequently treated preferentially with proton therapy because there is no advantage to irradiating uninvolved healthy tissue. If you can avoid that, don't do it.
Right.
So proton therapy, because you minimize the amount of radiation in a child, if you can, you will treat the patient with protons. Now, breast cancer, we talked about breast cancer. We do have a trial that is ongoing comparing proton therapy to conventional radiation because the study anticipates that you can minimize the amount of radiation to the heart, especially in left-sided breast cancer.
Of course.
When you're radiating all of the lymph nodes, then you end up radiating some of the heart with conventional modalities. So with proton therapy, you decrease the radiation to the heart. So that is estimated. This trial is being done to prove that you can reduce the risk of heart injury and heart problems that could be life-threatening. Now, the absolute benefit may be in the range of 3%. So out of 100 patients, 3 patients would be spared complications from radiation.
3%
that's still
is
a big,
3%?
It's still a big number. So this study is being done to compare and to prove that this is the benefit. It could be even larger than this.
When are the results of that trial coming out, if I may ask?
Well, it's a trial that will take several years to be concluded, but it's accruing, hundreds and hundreds of patients. It's estimated to have almost 2,000 patients in total, and all of the proton centers in the country are participating in this trial.
Fantastic. I look forward to hearing the results of that clinical trial. Anything when it has advancements in breast cancer is important to so many women out there. We have another video from the Miami Cancer Institute that uses an animation to show you how proton therapy works. Let's check it out. So overall, again, just to kind of wrap it all up with the proton therapy, you'd say that the side effects are minimal, right, compared to other therapies?
Right. So side effects in radiation are driven by how much radiation you're depositing in certain structures that are in the immediate vicinity of the cancer. So the more you can avoid putting radiation in these organs, the more you're going to reduce side effects. So obviously, we don't say with proton therapy is side effect free. No, that's not what we're saying. We're saying that we can minimize side effects.
All right, we have some images of some scans that compare radiation to proton therapy, so you can visually see maybe what the differences are. So, doctor, can you walk us through this and show us the difference?
So this is a comparison of, on the left column, you see something called tomotherapy, which
what is
we
that?
have. It's a machine that delivers conventional radiation X-rays.
Okay.
It's intensity modulated radiation. Okay. The machine is called tomotherapy. So we have all of the machines at the Miami Cancer Institute, but on the left, you see radiation that basically rotates around the body, coming through multiple angles, and these X-rays go through and through the body. So you do end up having more radiation that is deposited in the bowel, like for example in the central part of the image, the lower image. There's some bowel there, and this U-shaped yellow area is where the lymph nodes are. On the right column, you see proton therapy. Now you see a beam coming from each side, and the beam stops right on the lymph nodes, the yellow. And so basically, that bowel area at like 12 o'clock, right in the front part of the image, the lower one, that is avoided. So that's where we can clearly see that with proton therapy, we are reducing the amount of radiation in the bowel, bladder, that can effectively reduce side effects.
Can you break down the colors for me, doctor? Do they say something like the dark blue with the light blue with the yellow and the red?
Yeah, great question. And so the red is the higher dose. So the rounded area in the central part of the image is the actual prostate. That's where the highest dose is going. Then you have the yellow is where the lymph nodes are, and that's getting moderate to high dose. The blue is moderate to lower dose. And so basically you can see that large parts of the pelvis area on the right column you see there are not receiving any radiation. So that's basically the distinction between protons and conventional radiation. Tomotherapy is just one type of conventional radiotherapy.
And how successful is the proton therapy?
So it's really dose dependent. So if we with protons, we can escalate the dose, we can potentially improve disease control and even improve cure. That happens in some cases, like the chordomas. In some cases, with protons, we're looking to decrease side effects. It's still an improvement. Although the cure is kept at the same level, we're minimizing side effects. So there are two ways of looking at a better therapy. Is it improving cure and decreasing side effects, or is it just achieving at least one of those two? Because these two are ways to measure how good or how much better a treatment is over another.
Okay, and overall, I'd like to point out that the Miami Cancer Institute is the only cancer center with all radiotherapy modalities under one roof. And we have a graphic that shows, you see it right here, all of these 8 different treatments. So, doctor, walk me through these real quick, if you don't mind.
So on the upper line, we have a linear accelerator on the left. Then we go to a CyberKnife machine next. Then we have the tomotherapy, looks like a CAT scan or a donut. Then we have a Gamma knife on the right. That's used for brain tumors. On the lower line, we have on the left the MRI Linac, which is a newer device that can emit conventional radiation, intensity modulated radiation, having MRI imaging as you're doing the treatment. So it monitors the organ and the position of the organ. Is a very new device, unique in South Florida again. There are very few in the country. Then we have brachytherapy, the seeding, placing radioactive seeds in the prostate, and the proton is on the right. That image on the right lower part shows a school bus sized in relation to the treatment room. Those rounded structures are the gantries that rotate around the patient delivering the treatment.
My goodness.
So a proton facility, the equipment itself is about 3 stories high. So that's why that image is placed there to give you an idea of scale.
I was gonna ask you, why is there a school bus?
Well,
that's a fantastic image.
It's to understand how big this equipment is. And the cyclotron, the rounded structure there in that image that weighs 200 tons, 220 tons, is relatively small compared to the actual delivery devices that rotate around the patient, the gantry rooms. So these are very complex facilities. That's why there are not that many in the country or in the world.
Only found at Miami Cancer Institute, all of these 8 treatments. Thank you so much. All right, quick break. Our last segment is coming up. We're going to be talking about what's on the horizon for prostate cancer treatment and proton therapy, including research and clinical trials. The doctor mentioned one, but there are many more ahead. You're watching the Health Channel, all health, all the time on South Florida PBS. If you have a question for Dr. Fagundes, please call us using the toll-free number, 855-796-4475. Also visit our website, allhealthtv.com. You can watch previous videos from previous episodes or submit questions for the experts. We'll be right back. Stay tuned.
Make-A-Wish grants a wish every 17 minutes. I know that sounds pretty magical, but in fact, it takes more than magic. It takes muscle. So, when a kid like Fabian wishes to be a superstar, things happen. Whoa! Or when Kahim transforms into Super Kahim. He feels invincible. It's because wishes have proven physical and emotional benefits that can give children with critical illnesses a higher chance of survival.
Help us make sure every wish comes true. Join us at wish.org.
Don't allow your weight to threaten your health or control your future. Excess weight or obesity can cause emotional and physical health risks. But you can take control. The Your Weight Matters campaign offers free resources and tips to help you measure and understand your weight. Take the Your Weight Matters Challenge. The free toolkit prepares you to speak with a healthcare provider about your weight. Your weight does matter. Take the challenge and take control today.
A smile. It can show how we feel. It can change the course of our lives. But what would life be like if you weren't able to smile? It doesn't have to be this way. Since 1999, Smile Train has been helping children experience the simple joy of a smile. To learn more, call or go online now.
In Saudi Arabia, a genome research program is leading to major advances in precision medicine.
The Saudi Human Genome Program was facilitated by advances in technology, which provided us with the basis to rapidly sequence the genomes of individuals to understand the basis of disease, and this became easily related to the health and welfare of patients.
It's already helping doctors to more precisely diagnose and treat diseases like cancer, Alzheimer's, and diabetes. For more, go to thermofisher.com/precisionmedicine.
And welcome back to the Health Channel, all health, all the time. I'm Olga Villaverde, and with us is Dr. Mauricio Fagundes, the Medical Director of Radiation Oncology at Miami Cancer Institute. If you have a question for the doctor, please call us using the toll-free number, 855-796-4475. Precision medicine is something that is on the forefront of mainstream medicine. It's medicine that is tailored to you, and it can lead to better treatment of disease such as cancer. So we're going to take a look at this video that explains more about precision medicine.
What if you were offered the best treatment available, tailored just for you, to beat a disease like cancer or prevent disease in your unborn children? It's questions like these that are at the heart of precision medicine.
Many people think precision medicine is a fad, but it's the reality of the new medicine that is going to be offered to the population in a much more expedited manner, at a much more precise manner, and a much more economically efficient manner.
Precision medicine was one of the timely topics that took center stage at the 25th Bio International Convention in Boston.
Advances in precision medicine have been fueled by successful programs such as the Saudi Human Genome Program. The latest phase of this program screens couples before they marry to help them assess the risk of rare disease in their children.
This have been successful in preventing a number of disabilities by identifying these diseases early on.
The Saudi Human Genome Program was facilitated by advances in technology, which provided us with the basis to rapidly sequence the genomes of individuals to understand the basis of disease, and this became easily then related to the health and welfare of patients.
The technology is also leading to better treatment of disease. Statistics show 90% of the top-selling drugs only work for about half of patients. That includes drugs to treat cancer, diabetes, and Alzheimer's. By understanding a person's genetic makeup, experts can determine what treatments will actually work for them.
I think the ability to sequence and understand the genome of an individual has provided an opportunity for a better understanding of disease, for a better understanding of the patient, and through that, a better management of disease.
The Saudi Genome Project is a perfect example of how research, development, and clinical trials come together to really help a population. The earlier you can detect disease, the more likely it is you'll treat the disease effectively.
I'm Laura DeAngelis.
So, doctor, your thoughts on precision medicine?
So, I mean, these are new developments in medicine, right? You know, targeting receptors, targeting cell function. So, I mean, combining this with newer modalities of radiation is going to be a really interesting development. We are radiating less and less of the body. There's potential to minimize any impact of radiation, even in the immune system, as there is, you know, in reducing medicines that affect the immune system, like chemotherapy, and doing other medicines like targeted agents. So it's going to be interesting to see how this develops.
And talking about development as well, clinical trials on prostate cancer also in the horizon?
Right. So we will have a trial opening that will be comparing proton therapy to conventional radiation to actually measure and prove, demonstrate the magnitude of benefit of proton therapy. So this is something that is being, you know, done nationally. Even some of the insurance companies want to know, you know, how much better can this be? So this trial is important. So we do support it, as we do support the trial comparing the treatments in breast cancer.
And these clinical trials really are important. They take several years. There's no doubt it's time consuming, but eventually they do give a lot of information.
This is the time to do it because proton therapy technology now is the most evolved and it's capable of doing the best proton treatment we can do. So this is the time to do the trials. In the past, the technology was not up to the point where it is now. So now we should be doing these trials. We should be supporting the trials.
Is proton therapy covered by insurance today, doctor?
Most Medicare covers across the board.
Oh, that's fantastic.
Many insurances will say, well, if you can demonstrate to me comparing the two on a dry run, a plan that we do, if we were to do the treatment with this modality, this is how much of the heart we would radiate. If we do it with this modality, we reduce the radiation. Sometimes the insurance will ask for that information to approve protons. So basically, yes, I would say that it's, for the most part, yes.
And
covered.
speaking of proton therapy, the doctor will be traveling tonight to India, for work surrounding proton therapy. Are you excited about going? Have you been there?
No, not yet.
No?
So yeah, very excited. There are, I think, 4 lectures that I'll be doing. We're collaborating with a center that has the same equipment we have.
Oh, really?
So these colleagues, doctors and physicists, have spent time here, you know, seeing how we do what we do. And so they're getting up and running now, and they're going to be starting treating patients in the next few months. So yes, it's very interesting.
So you're going to be very busy lecturing them, informing them, and giving them the know-how that you know at this point. Yeah. How long are you going to be there?
About a week and a half.
A week and a half? How many hours? I mean, I'm just India. How many hours is it going to take?
Far, yeah. It takes about a day to get there between 2 flights and yeah.
Oh my gosh. Okay, any sightseeing?
Maybe.
You're like, maybe. I'm so excited for him.
Yeah, after I rest, yes.
Tell me you're going to go see the Taj Mahal. Please, please, please.
I hope. I can't promise.
Well, you're going to have a wonderful time. All right, we only have about a minute left. So for any man or a wife out there that she just heard that her husband got diagnosed with prostate cancer, what are your final thoughts for that person?
Well, I think that, a second opinion is always a good thing to have. And patients can learn if the technology, we have all of the technologies, and these are all great technologies. Proton is just one of them. And they should just, if they call us, they have a consultation, they'll have all the information if this is appropriate for them, for their case, and yeah, so.
And early detection is huge, and the success rate is fantastic. We said it right at the beginning of the show, 99%.
Early stage prostate cancer is extremely curable.
Fantastic. Well, have a great time in India.
Thank you.
Come back on the show and bring us some pictures.
Will do.
Yeah? All right. And if you go to the Taj Mahal, think of me.
Yes.
Take a picture and say, hey, oh, God. Safe travels, doctor. Be sure to join us next time on the Health Channel. All Health, all the time on South Florida PBS. Follow us on Facebook and Twitter at All Health TV, where you can get health tips from our experts and see what's coming up on the Health Channel. Also, you can visit our website. It's fantastic. It's really good. allhealthtv.com to submit questions for the experts or watch videos from previous episodes. I'm Olga Villaverde, and we hope to see you next time.